I am just excited to give this talk. And as I said, I wasn't quite sure how much information was required for this kind of talk. And so some of my slides are they have a little bit more information, but we can go through slowly. And at the end of it, if you want me to go back to a particular slide that you were interested in, we can go through and I can explain it in a little bit more detail. I don't have all that many slides, but I just wanted to take enough time on each slide. So I'm actually a pediatric neurologist. So I see kids, and I also do sleep medicine. But I've been interested in dementia and changes related to sleep. And so when this opportunity came up, I was very excited. Oops. Okay, I seem to have got this stuck.
Well,
It was working just now.
oh, I had it on laser pointer. Okay, let's see.
I wonder if
Okay, try it now.
accidentally.
Okay.
And I think that was you.
Yes, I'll go ahead.
Oh,
You can
you?
just let me know.
All right. So I don't have any conflict of interest. I'm basically an LSU employee, and I also work at Asghar. If we can go to the next slide. Okay, so our objectives, I think what I want you to take from this talk today is number one, I want to review some basics of normal sleep and talk about how do these change when we get older. And then we are going to look at what kind of changes do we specifically see in dementia. And then what are some of the strategies that we can use to help with these sleep issues. So next slide. Okay, so this is a busy slide, but it looks at what is normal sleep. So normal sleep, if you think about it, you may think that, okay, I'm sleeping, I'm not doing pretty much nothing at all. It's actually a very active state, and a lot of biological processes occur, and one of those processes involves memory consolidation. So it's very important. And then it involves different stages of sleep, as you can see. Initially, you're awake, and then you slowly go into stage 1, 2, 3, and 4. 4 tends to be the deeper part of sleep, or that's called slow wave sleep. And then immediately after you go into stage 4, you get your first REM period. So REM means rapid eye movement, and the other stages 1, 2, 3, and 4 are non-REM, non-rapid eye movement sleep. And so what happens is that you have these circles through the night, and you can see that your REM increases towards the end of the night, right? And then the other thing we have to think about is, so what's different? Why call it REM and non-REM? So during REM sleep, it's a very important part of sleep because a lot of things are going on. Your blood pressure will be increased during that time, heart rate can be increased. So a lot of activity is going on even though you're fast asleep and your tone is kind of very low. But your eyes, there's movement. That's why it's called rapid eye movement sleep. Your non-REM, usually your blood pressure goes down, your heart rate goes down, and this is when you get a little bit cold. So initially when you go to sleep, you like to snuggle in your blanket. That's because your body temperature goes down, right, initially. Now the percentage changes. So usually if you have a baby, they'll spend 50% of their time in non-REM and 50% of their time in REM sleep. But in adults, you can see that the REM sleep goes down and the non-REM sleep kind of increases as you get older. So these are the stages of sleep. And the other thing to remember is our first REM period of the night occurs after 90 minutes. So about almost 1.5 hours. Then we get our first REM. So some people might say, that, hey, I don't get enough REM, but you really have to wait for a period of time before that REM occurs. Okay, next slide. So what happens when we age? And these are normal changes that you and I go through. And what happens is if you look at both these graphs, so when you have a younger person, you can see that it's spread out. You have a nice REM. The REM is the black bars over there. And as you get older, what happens? The REM becomes less. And you also see that these are these stages where you become awake through the night. So what happens is, as you get older, there are episodes where you arouse. You arouse more than when you are a younger person, and that's normal. The other thing that occurs is you spend less time in stage 4, if you can appreciate that. So you don't go into deeper stages of sleep anymore. At most, you may go into stage 1, 2, and 3, but most of us may not go into stage 4. It differs from person to person. This is just the general, general information what happens. So what happens is then the other peculiar thing that happens when we get older is we have this advanced sleep phase. What does that mean? That means that, you know what, we prefer to go to bed early and we get up early. Some of us wake up at 4 a.m. We start our day at 4 a.m. as we get older. And that is very normal. And then you have increased in arousals, as we said, because now you're having all these little areas here where you wake up, right? So you have arousals. The sleep becomes lighter because you don't go into the deeper stages, and it's more of a fragile sleep. And the other thing to remember, as I said, REM decreases. And this decrease is even more after age 80. Okay, so we can go to the next slide. Okay, what are some other changes that you see as you get older? So one thing is you take a longer time to fall asleep. So longer sleep latency. And that might be perfectly normal for you. The other thing is shorter total sleep time. So the amount of time that you spend sleeping becomes less, if you look at that. So now you're spending 6.5 to 5 hours of total sleep, whereas when you are a child, you may have spent 9 to 15 hours sleeping. So that's a bit of a change. Then latency, so it takes a longer time to fall asleep. And then we said several arousals when you fall asleep. And then we talked about the stages of sleep, and some of these reduce as we get older. So we can go to the next slide. Okay, now, why do we sleep? Why does that happen anyway? So that's related a lot to melatonin production. So melatonin is called the chemical expression of darkness. So what happens is, as it becomes dark, your pineal gland, this picture, it will secrete melatonin. So there's melatonin production as it gets dark, and the melatonin makes you feel sleepy. It tells you, you know what, it's time to go to sleep. So the thing about melatonin is, as we get older, the melatonin production also goes down. So that you have to keep in mind, because when the melatonin production comes down, that's when we start having problems like insomnia. I'm not feeling sleepy. And that's because our melatonin has gone down as we get older. And so you see that as you get older, 60, 70 years old, really that production becomes pretty low compared to a young child or a newborn infant. The other thing I wanted to show, which is so, I think, interesting, is that melatonin is very related to serotonin and tryptophan production. So all this goes hand in hand, and I'll tell you why that becomes so interesting. So just keep in mind that melatonin is probably a byproduct of tryptophan, which is a normal amino acid in our bodies, and it's also found in food products. So this is that, and then let's see, I think I went through all this. Yeah, we can go to the next slide. Okay, so now what we're going to do is we're going to quickly review dementia. I know that all of you know a lot about dementia, maybe Alzheimer's or frontal lobe dementia, but I just want to review it because then it makes sense when we look at changes in sleep in dementia per se. So what are the types of dementia? First of all, it's common, especially in people over 85 years old. 45% will develop some sort of dementia. And why does that happen? Because age is the greatest risk factor for dementia. Because you can see a lot of processes come down, and a lot of processes, even sleep, affect our cognition. You know, and so we may not have full-fledged dementia, but we could have mild cognitive impairment, or we could just have forgetfulness, you know. And types of dementia, Alzheimer's, that is the most common. Then you have vascular. What does vascular mean? Vascular means some of us have had many strokes. So over time, those strokes will give rise to what is called vascular dementia. So you may still have problems with memory, or your thinking may be reduced and it impacts your daily life, but the cause is because you've had multiple strokes over time. So that's vascular dementia. The other one is Lewy body dementia, and then frontotemporal, and others are Huntington's, and also dementia from more than one cause. Because it doesn't necessarily have to be, you may have Alzheimer's, but you could also have vascular dementia at the same time. So I think our next slide shows a little bit, yeah. So I put this in because when we talk about things like Alzheimer's, frontotemporal, Lewy body dementia, a lot of it is related to these proteins. So what happens is, for some reason, maybe because of inflammation or other reasons, there's more deposition of these proteins. So in Alzheimer's, the proteins that are implicated are the tau protein and the amyloid B. Whereas in dementia with Lewy bodies, you have your alpha-synuclein. That's also implicated in Parkinson's disease. So causes may be a buildup of these proteins where it should not be built up. So it gets built up for unknown reasons. We don't know why. What happens? Sometimes they say that it might be genetics. So maybe grandmother had it, great-grandmother had it, and now you have the same thing. So it could be genetic. And then we said changes in blood vessels. So for example, if you have stroke, you may not necessarily have protein deposition, but it affects your blood vessels over time. And then that can cause changes and symptoms that are seen in dementia. And then genetic we talked about, so we can go to the next one. Right. So again, you see, dementia, the common symptom that we see is that the new memories, what happens is that's affected. So now we can't remember things that we should. And normally the first one that goes is short-term memory. And then sometimes what happens is we have trouble with communicating. Planning, organization becomes a bit of a problem. And a lot of times, before it was very easy to do your checkbook at the end of the month or make your budget, but now it's like, that's a problem, right? And then navigation, typically, what happens is that familiar places look unfamiliar and you get lost. It's like, I don't know, I just couldn't find my way to Kroger's, whereas you did it for so many years. So those are some of the early symptoms. And then later on, and also depending on what kind of dementia you have, you might have personality changes, you could have depressive symptoms, anxiety, delusions, hallucinations, particularly because it also depends which part of the brain is affected. So if you think of frontotemporal dementia, means the problem is in the frontal lobe and in the temporal lobe. And we know that frontal lobe is very important for memory, behavior, thinking. Temporal lobe is important for hearing, feeling, So frontotemporal, a lot of times with that kind of dementia, you may have personality changes, aggressiveness, trouble thinking, or making decisions. And this one, I put this to show the difference between a healthy brain and one that has Alzheimer's. And right away, what do you see with this? What strikes out? Is smaller, right? So then the thing you have to think about that, wow, if this shrinks, and this is the area of my brain that is so involved in thinking and processing, if that reduces, then definitely I'm going to have trouble with that, right? So that's why I put this, just to show that it's so important to think of the symptoms related to areas of the brain, and then it makes sense. Next slide. All right, how do we diagnose dementia? In this day and age, I think if you have some of those signs and symptoms that you think, I really should not be having these signs and symptoms at this time, then you need to go and see your doctor. And what they normally will start off by doing a history and a full examination, because remember, sometimes you may feel that, I can't remember these things, something is wrong. It may not be wrong. It may be related to, maybe you're on a medication that's making you, have trouble remembering things. So you definitely want to go to your doctor and let them do a good history. and then they'll do a neuro exam. Many times the next step will be a neuropsychological evaluation. They'll get to you to do particular questionnaires, and they'll have you fill in, and it's pretty, I think, quite a comprehensive test that they do, and a lot of times it can even give a clue as to what dementia the person is dealing with after the neuropsych testing. And then of course there's more sophisticated testing like MRIs, a SPECT study, and PET. What that means is an MRI is just a very sophisticated, it is a three-dimensional way of looking at the inside of the brain. Now PET and SPECT just means that they inject a dye, and the dye comes up, and then you can actually see which part of the brain lights up and which doesn't. So in this picture, if you look at it, that's what we're looking at, which areas are bright and which areas are not. Because when you have areas that are not bright, for example, this is an image in a patient with Alzheimer's disease. So you know right away that this area is not brightening up like that one, normal. That means that probably this area is not working as well. So it gives a clue that maybe I am dealing with Alzheimer's kind of dementia. Now in mild cognitive impairment, these areas are affected, but not to the extent as this. I mean, you can appreciate that, right? And so this gives a clue as to what exactly we're dealing with, because it's helpful for management and treatment. And then other studies include CSF studies, taking spinal fluid and sending that off to make sure that there's not other things like infection which might be causing this long term. And then EEG. EEG simply means leads are placed on the head and they look at brainwave activity. And a lot of times in dementia, it becomes slow. You want to rule out metabolic, nutritional deficiencies, infections, medication reactions, because, you know, nutritional deficiencies like lack of vitamin B12, chronic vitamin D deficiency can really affect sometimes your memory and thinking. So the doctors have to rule that out, because those are things that are treatable. You can change that, right? And psychiatric problems, because if you have depression, a lot of times if you are depressed, you're not going to remember things. It's going to affect your memory. And those things are, the treatment is different, the management is different. Okay, next slide. Right, what about sleep? So how does dementia, what is the interplay between sleep and dementia? Because now we know what are some normal changes in sleep, and we know as we all get older, our sleep is going to change. But in dementia, those changes are very pronounced. They're not, that's why it's no longer normal, because it's just too much beyond that. And why? Why does that happen? Because if you look at Alzheimer's disease, remember we had these proteins involved, you know, beta protein and tau. And a lot of these proteins are very closely related with what happens in sleep. So if you have decreased slow wave sleep, it is an indication that there's a buildup of these proteins. It's not being cleared properly in slow wave sleep. And I put the other sleep disorders that could be related to Alzheimer's, things like insomnia, sleep deprivation, obstructive sleep apnea. Now, obstructive sleep apnea is something that's treatable, and we'll talk about, I have a separate slide on that. And then, as I said, a lot of it is because of neuroinflammatory causes for some reason. Maybe because of metabolic, cardiovascular, cerebrovascular compromise. All this means is strokes. If you've had multiple strokes, or cardiovascular, if you have history of hypertension, untreated hypertension, or treatment-resistant hypertension, cardiac problems. Sometimes what happens is those diseases chronically can cause changes in this. You know, it may cause neuroinflammatory markers to be secreted. You may then get obstructive sleep apnea, have all these changes, and over time you may have risk of Alzheimer's disease. This is an area of research that many people are interested in and looking at it. I'm interested as well in that, if obstructive sleep apnea might be a marker for Alzheimer's disease. But anyway, that's just to show you some of the players in dementia with sleep. Right. Okay, now specific changes. So just now you looked at what are the chemical changes that you might see, but what are the other changes that the doctor will diagnose you with if you have dementia? So there was a very good review that was done, and what they found was that in patients with dementia, 60% of them had sleep disordered breathing. Now, what do I mean by sleep disordered breathing? That is related to obstructive sleep apnea. Obstructive sleep apnea is a sleep disordered breathing, but it's a more pronounced sleep disordered breathing. It really affects you. The next common symptom that people were having with dementia was excessive daytime sleepiness. They were falling asleep again and again, which was not normal for them at that stage. And then insomnia, can't sleep at night. 50% of them had trouble with insomnia. Some of them had trouble with REM, sleep behavior disorder. Now we know what is REM. We know that REM decreases, but some of them had problems with their REM sleep as well. And I'll show you slides with that. 6% had restless leg syndrome. And I think we're all kind of familiar with restless legs, right? And this is the urge to sometimes move your legs, and once you sleep and rest, that urge goes away. Periodic limb movements of sleep, that's also connected with restless legs and REM sleep. And then circadian rhythm disorders and other non-specific sleep problems. I have a separate slide on circadian rhythm, so we'll talk about that a little bit more. Can we go to the next slide? All right, so before looking at our sleep problems, how are we going to diagnose it? So we went to the doctor. We think that, well, maybe we're getting dementia, and the doctor does evaluation and says, you know what, I think you have a sleep problem. Let's go further. So what they can do is they can do a sleep study. A sleep study or a polysomnogram is very useful study to rule out obstructive sleep apnea. And it's an excellent study because you go in, they put leads on your head to look at EEG changes. They put 2 prongs in your nose to look at nasal flow. You have 2 belts on your abdomen and your thorax to see how much air you take in. Then you have oximeter to look at your oxygen levels. Then you have EKG leads. I think, and I may be biased, I think that the sleep study is one of the most comprehensive studies out there. And you get all this just with 1 night of sleep. It gives you all that information. The other thing, of course, is many patients who have started having dementia and changes may not tolerate all this at night. They may not be able to tolerate leads on their head. So what's an easier way that we can do? That comes your actigraphy. So what is actigraphy? Actigraphy is simply a watch that's put on the person before going to sleep, and most people can tolerate that. And what it picks up is movement. So for example, if the patient is not sleeping and is pacing up and down, that gets recorded on the watch. So you can actually tell how much sleep that person is getting at night without having to go through this. Of course, you can't beat a polysomnogram because the information that you get from that is so much more, but this is an option that could be used. And then of course we have questionnaires. This is a really nice, easy questionnaire to look at obstructive sleep apnea. So the questions they'll ask you is, has anyone observed you snoring or stopping breathing at night? Is it yes or no? P, do you have high blood pressure? Is your body mass index more than 35, so you're a bit heavy set? And age more than 50 years? What about your neck circumference? Is it more than 17 inches for males or more than 16 inches for females? And male, is it, because you see, if you're male, unfortunately, you're at higher risk for obstructive sleep apnea. So if you add that all, you say yes, 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 and you have 4 yeses, then your score is higher, and so you're at higher risk for obstructive sleep apnea. Immediately that gives you information. The other questionnaire that we use is called a sleep diary. And this is very easy to fill because all it is different timings during the day, and you have to indicate with a straight line, for example, what time you went to sleep. A is, did you have a last drink of wine before going to bed? Did you have a last smoke or cigarette before going to bed? So this is filled over a 2-week period, and it really gives us information as to how well you're sleeping and are you doing things that are really making your sleep worse. So that's the information it gives us. So all these together gives you a good idea to your doctor what kind of sleep problem you might have, and not necessarily dementia per se at that point. Next slide. Okay. The first one, as we said, this was the most common in adults over age 60. 50% reported insomnia, and 50% with dementia had problems with insomnia. So what do we mean by insomnia? Now, most of us know that it means that I'm laying there at night, maybe counting sheep or whatever, and not being able to sleep. But that's not the only definition for insomnia. It also means that you can't maintain your sleep, meaning that you're getting up at different times during the night. That means your sleep is not well maintained. So that's also insomnia, right? And the other thing to think about, which is kind of scary, because insomnia has an increased risk of Alzheimer's disease. Yeah. And multiple causes of insomnia. They can be medications, because you could be on a medication that's keeping you wide awake at night, you know, or sleep disorders, as we said. For example, if you have obstructive sleep apnea and you're waking up multiple times during the night, you're snoring and then you're gasping, that keeps you awake at night. Medical or psychiatric disorders, for example, people who have bipolar or deep depression, they may not be able to sleep at night either. So they could be having insomnia. Behavioral or environmental, and this happens a lot. Like, for example, in a nursing home, you're not used to that place. That's not your familiar place. And so now what happens is I can't sleep on top of it. On top of it, I'm having trouble with my memory, and now I'm in this unfamiliar place. So now I have insomnia, which makes things just worse. This is a nice diagram because it just shows the interplay between insomnia, sleep disturbances, those proteins that we talked about, and inflammation, and then chances of Alzheimer's disease and the risk of Alzheimer's disease. And I've just explained here what happens with all that. But just to, you know, I think by now you must have realized this is a really big interplay between all these different factors. Sometimes it's very difficult to know which came first, the chicken or the egg, because now we have all these things occurring in the same person. It's really difficult. But at least if we know, because you see, if we don't know, then we can't do anything about it. But if we know, maybe some of this we can work on and we can treat it. Next slide. Treatment. So sometimes if the insomnia is unbearable and it's really affecting someone, they cannot function, in the short term you can use non-benzodiazepines or melatonin. I have another slide of melatonin. Melatonin is very popular and it's safe. The other one is, a lot of times in nursing home patients, they get put on atypical antipsychotics. The thing about that is that sometimes what will happen is they'll start having more agitation, confabulations. That means they're just making up stories. It's very real to them, but it's not real, right? And then low dose antidepressants can be used, but they can increase restless legs. So remember that a patient with dementia, any kind of dementia, is very fragile. So a lot of times these medications might be fine in you and me, but if you give it to someone with a fragile brain, then they may have more side effects than you would not have expected them to have. The other thing is stimulus control. You want to control drugs or medications given in the morning, you know, common drugs like diuretics or bronchodilators or corticosteroids, because this, if you give that close to bedtime, of course I can't sleep. Steroids make you awake, give you insomnia. Cardiovascular agents, H2 blockers like propranolol. So normally what we say is, if you know these medications are causing my loved one to have insomnia, give it in the AM or 6 to 8 hours before bedtime, because by then the effect is probably worn out, right? So next slide. Melatonin. Melatonin is something that is very, very common. It's available everywhere. It's over the counter. This is a nice big bottle of melatonin. If you look at it, the ingredients, you see that it has 10 milligrams. It's safe to use. You can start dosing from 1 milligram to as high as 15 to 20. But when I say that, it's really important to get your doctor on board as well. That we're, hey, you know, we're interested in using melatonin. Can we go ahead and start and, you know, have them also involved? The thing about melatonin, if you look at the kinetics, once you get to 15 to 20 milligram, it reaches a plateau. So beyond that, if it didn't work at 15 milligrams, it's not going to work beyond that. So you don't want to go beyond that. And there are many over-the-counter products. Here's where the problem starts. Because the problem is that it's not FDA regulated. And so a lot of times that the products that you get may have different amounts of melatonin, or it may be combined with something else. And I've seen many products, sleep aids they call it, and you may have melatonin combined with a different product to help you sleep. So you want to check that, and you want to be careful about that. A lot of times you can get your doctor, they don't really need to prescribe it, but if you're worried, you can get them to actually write a prescription and see if your insurance will cover it. That you can do, but most of these are really, they're safe, and you know, you can use them, and it's very, I think, you know, there have been cases where you can overdose on them, but most of the time it's happened when you have other stuff going on and you're on other medications, and now you take a bunch of melatonin on top of it. Next slide. How can we get melatonin naturally? We know that melatonin is good. We want melatonin. We know that as we get older, it's decreasing. So where can we get this melatonin? So foods like pistachios, green beans, portobello mushrooms, sprouted kidney beans, lentils, black rice, grapes, wheat, barley, tart cherries, tomatoes, bell pepper. All of these foods have melatonin. So you really want to add that to your diet. The other thing is go outdoors, but you have to be careful with what time you go outside, because remember, melatonin is secreted when it becomes dark. So for melatonin exposure, it has to be natural light, it has to be morning, and you shouldn't wear your eyeglasses without your sunglasses. So that's why, you know, in the morning time, it is good to maybe take your loved ones and let them sit out, soak in the sun. You don't want to do that in the afternoon, you know, closer to bedtime, because then they'll be wide awake, they won't sleep. And so you want to do that at the right time. And then if you do it at the right time, it makes it easier for them to fall asleep at night. So that's a natural way for the melatonin. Now, the other thing that we are doing a lot, oh boy, we are so technically, we're at the technical age, because some of us, we need our iPhone, we need our iPad right before going to bed, and guess what? That has a lot of blue light. And what happens is the blue light actually suppresses melatonin. And then guess what happens? You're wide awake at night. And so what happens is you want to decrease that. How can you decrease that? You can get screens, protective screens. iPhones are very cool because you can have a different program at night, meaning that they change the coloring on your iPhone at night or when it gets dark, that has less blue light coming to your eyes. Other things you can do is, you know, use fluorescent, cut back on LED lighting. Once you get in bed, avoid watching television, because many of us, I mean, we like the TV on when we go to sleep, and that sometimes is not helpful at all. And so this is blue light, and we definitely want to make sure, especially for our loved ones, say you have someone in, say, in the nursing home, and many of them have televisions, you know, to keep them, you know, keep them occupied in the daytime. So you want to make sure that they don't put it on accidentally at night, otherwise they may stay awake. Next slide. Okay, so we remember that melatonin is a kind of a byproduct from tryptophan and serotonin. Remember, I mentioned that? And tryptophan is an amino acids, and guess what? It is found in foods as well. And what kind of foods is it found in? Lean proteins, low-fat cheese, chicken, turkey, egg whites, soybeans, pumpkin seeds. So all this will actually, if you think about it, indirectly increase melatonin, right? Unsaturated fats, peanut butter, walnuts, almonds, cashews. And the other big thing is exercise. Exercise actually stimulates serotonin secretion. So these are some things that you could do, and these are again natural ways to increase your serotonin and therefore increase your melatonin. Next slide. Other foods for sleep. So not only tryptophan, serotonin, and melatonin, magnesium. Actually, magnesium also helps with sleep, and it's found in spinach, avocado, black beans. Then, of course, a good soothing beverage. And remember, your mother used to say, always have a glass of warm milk. She was right. It really helps. And things like herbal teas are very popular, chamomile tea, and that actually helps you, get to sleep. Peppermint tea. The other one that I thought was very interesting is fresh herbs. I didn't know that basil and sage, I mean, if you made homemade pasta sauce and you use that can actually help you. Now, what are things you should avoid before bedtime? The foods you want to avoid are, now you don't want a caffeinated drink right before bedtime, coffee or tea. And you don't want a heavy meal like, French fries and, I don't know, chicken nuggets or whatever. You don't want that right before going to bed. And then acidic and spicy foods, it doesn't help. Sugar and refined carbohydrates also does not help because they actually suppress melatonin. So you don't want that. Because remember, melatonin is good. We want melatonin. Alcohol is not helpful. And then, of course, going to bed hungry. That's not very good, because then what happens is that makes you may sleep for a little bit, but then you might get acidity and you might get up. And these are just looking at all the foods that are good for sleep. Mindfulness. How do we get to sleep? The other thing is relaxation, calming down, deep breathing, yoga. And these are some relaxing activities like coloring book for adults. It's really good, and they have it in big sizes, because I know that sometimes when you get dementia, your coordination is not very good, and that we don't want to frustrate them. So you want something that's easy that they can do. Meditation is very important. And then, church, because, some of the people that are getting dementia are maybe your mom, your grandmother, and they were so tied into prayer, going to church. And that is what makes them relax and helps them calm down. And this is a prayer that I found. I was so amazed that there is a patron saint for Alzheimer's and dementia. I did not know that. It is, what is the name of the saint? Dimfa. This is the Catholic, it's a prayer card. I found that on the internet, but I thought it was so nice to have that. And one can just pray it for someone who's having trouble sleeping. The other one, I found a good book, Mindfulness Training for Those Living with, it's called Dancing with Elephants. And I think they give you different hints and activities that you could use with your loved ones. Then, of course, you want to keep the schedule the same. So if you have a beloved mom that was always, every Sunday we'd go to church, we'd do all this. Now we're in a nursing home, we still keep that, So visits with the chaplain, maybe if we can't go to church, then online church. And that's all available, because you want to keep, the same for your mom, because in those periods where they have lucid, those are things that they remember and they feel comforted. Those old hymns that they used to sing. And then listening to music, whatever they liked. Maybe Elvis Presley, so well, let them have Elvis Presley then. Next slide. Okay, tips for the caregiver, and these are some very simple tips. Regular sleep-wake cycle, go to bed at the same time, get up at the same time, engaging in relaxing activities, as we said, coloring, prayer, meditation, limiting light exposure prior to bedtime, and we said that, be careful, don't let them be on their iPhone, keeping sleep environment quiet and comfortable. And this is sometimes hard because, in a nursing home, it may be noisy, you may have a roommate. And so those things are difficult, but I think most nursing homes, they're really good and they want everyone to be comfortable and to sleep at night. So this is something that you might want to keep an eye out. Avoid caffeine, alcohol, or tobacco in the evening. Avoid naps greater than 30 minutes during the day. And so naps during the day should be things what we call power naps, 15 to 20 minutes, no longer than that. Because remember our cycles, first we start off going into stage 1, stage 2, stage 3. Now, if you're going to nap for 30 minutes, you're going to go into deep sleep. And that's very disruptive if you wake someone up, after 30 minutes because they want to sleep. And then at night, guess what? I can't sleep because I already slept during the daytime. So you want to limit those naps. And then these are some nice, easy sleep-inducing snacks. Banana with low-fat yogurt, low-fat cottage cheese with whole grain pita chips, peanut butter on whole grain crackers, apple with mozzarella string cheese, tart cherry juice. So these are some things that, you could, when you go and visit someone, say in the nursing home, and they've already had their meal so early in the day, they need a little snack before bedtime. These are something easy things you can take with you. And they would enjoy eating that, I think so. Right. The next one, as we said, that's commonly seen in patients with dementia is excessive daytime sleepiness. So what's happening is they're taking multiple naps during the daytime. What are those causes? It may be because, they're bored. There's lack of activity, lack of stimulation. And so what do? Sit and sleep. And I've seen that. It's hard, I think, in the day and age that we live in, short staff, not enough recreational therapists or things like that, that becomes a bit of a problem. And then comorbid conditions like depression. Depression makes you either very sleepy or can't sleep at all. One of the two. Sleep disorders, as we said, if you have history of heart disease or head injury, what happens is that, during the daytime, then you don't sleep well at night, and then you're just sleeping, little naps during the day. Diagnosis, again, you can do polysomnogram, actigraphy, as we said. Right. The most common cause of excessive daytime sleepiness is, guess what? Medications. So you really have to look into it, and you have to check, like your mom, if she's in the nursing home, you have to check the medications and when are they giving those medications. Because these medicines, some of them are very common, like cimetidine and ranitidine. Those are to prevent acid reflux. Those are very common, and they can affect your sleep or make you so sleepy, right? So if it's making you so sleepy, you want to give it closer to bedtime, not during the daytime. Then antidepressants, these are some examples: trazodone, amitriptyline, imipramine, venlafaxine, antipsychotics. Now quetiapine is used a lot in patients in nursing homes, but again, it depends on when you give it. If you give it earlier on, then yep, the patient is going to feel sleepy and going to take multiple naps. Antispasmodics, oxybutynin, this is used in patients with chronic UTI. It's fairly common. Then anti-Parkinson's. So if you have a loved one who has a diagnosis of Parkinson's and is on these medicines, they can actually make you very sleepy during the daytime. And then other medications, a lot of times they are used to control pain. And so what happens is side effects of these medications, we said, increase sleep, but it can really affect your cognition in the sense that it can make you more confused and you have increased falls, which is dangerous for someone who's already so fragile. Now, the other one that we need to talk about is circadian rhythms. So what do we mean by circadian rhythm? So circadian rhythm means the most common example is your sleep-wake cycle. You go to sleep, you get up in the morning. This is the cycle that you follow. You get up in the morning, and then by 7:30 a.m. melatonin stops, and so you're wide awake. Your best coordination time is at 2:30 p.m. in the afternoon, and then sunset. Here is where you might have high blood pressure or high body temperature, but once the melatonin starts, everything slows down and you go to sleep. So that's called a circadian rhythm. And lots of other functions in our body are related to the circadian rhythm, like blood pressure, like heart rate, behavioral, and this repeats every 24 hours. And I wanted to mention that because our next slide, that comes in, because when we have disorders affecting our circadian rhythm, it may mean that it might be affecting this suprachiasmatic nucleus. This is called the supermaster nucleus, because this one really controls circadian rhythm. and it is related a lot to light and the hypothalamus. And so what happens is the SCN, the suprachiasmatic nucleus, controls the production of melatonin. So important, right? Because without melatonin, we're not going to be sleepy, we're not going to go into a sleep-wake cycle. And I've just written how that goes through to the brain, and then it goes through the eyes to the brain. And so when there is less light, the SCN tells the brain to make you more sleepy, and so you get drowsy. The other thing also to think about is environment. Again, say in the nursing home, you're in a room, and it doesn't have a lot of light coming in. So then what happens is you're not going to secrete as much, melatonin, and it doesn't follow that natural 24-hour cycle when you should be getting enough light during the day. Right. So what are the disorders? Disorders simply means that now we're not following our circadian rhythm. We may be just, getting up at 3 a.m. and we want to sleep during the day at noon. So we're not following the circadian rhythm. How can that happen? Well, if you damage the master nucleus, we have a problem then, because you don't have, the melatonin secretion is going to be abnormal. If you have problems with your eyes, because remember, the light goes through your eye. The eye is very important. So remember, people who are blind, a lot of times that affects their circadian rhythm. Or if you have glaucoma, macular degeneration, then that's going to affect your eye. The other common example sometimes we see are jet lag. So if you travel to other places with a different time zone, that can affect your circadian rhythm. And it's worse still if you take mom or dad with you and you go to Alaska. So you may need 2 to 3 days to get back to a normal circadian rhythm. Shift work is very important, because shift work means that you're working at night when you should be sleeping. So if you do that long term, that can really mess up your circadian rhythm. And then irregular sleep-wake cycle, I think it happens. People with dementia, sometimes they can have 3 or more irregular sleep bouts per 24 hours. And then what happens is their behavior worsens. And they have this thing called sundowning. Has anyone heard of sundowning? You go to next slide. And so sundowning is a problem, because what happens is the person is confused, they're anxious, they're pacing up and down, they're disoriented, and usually what happens, it starts at dusk when it starts getting dark, and it continues throughout the night, and that can be a real problem. So what do we do about it? Next slide. So the effect, one thing we have to remember is usually it tends to start occurring when you're newly diagnosed, when the disease first starts. And somehow over time, this sundowning effect tends to get better. And so what triggers it? A lot of times it's exhaustion. For some reason, maybe you shouldn't be doing so much activity. You have a very rambunctious physical therapist, and the person is so exhausted and tired that by dusk they are agitated, pacing. New environment, and I think that's very common, especially when you first go to a nursing home or a different place. Now this one is very common, changes in caregiver or shift in facility, because remember, staff changes. So the day staff, they leave. And I know that older people, when you're attached to someone, and then by evening someone else comes, it's a shock, like, who is this person? And so that affects. And then simple things like UTI, that can really cause sundowning. You're agitated. And the other thing that happens is a lot of times the caregiver doesn't understand, because they go in the daytime when the parent is doing fine, because these problems occur when it's dusk. So very important to listen to what they're telling you, your nurses, the report. And then, non-verbal behaviors. So if you're not clear, you're not telling them, but you have a non-verbal behavior that they don't understand, it causes anxiety, frustration, because they don't know what you're thinking and what you mean by that. And that causes confusion. And this is, of course, a great source of stress and family caregiver burnout. Tips: visit the doctor to take care of bladder infections. So if you think mom is having a lot of sundowning, going a lot of times to the bathroom, take her to the doctor. Maybe she has UTI. Treat it, she'll get better. Or even constipation, And then appointments, have it early in the day. You know, you don't want it later on where you can affect your melatonin. Minimize stimulation in the evening. Restrict caffeine. We don't want the television. Instead of television, have soft music in the evening. And then have a larger meal at lunch, and then keep the evening meal light, right? And we mentioned avoid alcohol, caffeine, and nicotine. Then soothing activities, we mentioned that. Create routines, so important. Even if it's something mundane, like you go every day to visit your dad, and maintain a schedule. Okay, when I go, it's getting later, I'm gonna do the curtains, I'm gonna do this, I'm gonna sit by him, I'm gonna read his favorite book. The same thing every time. Try and keep that. And because that gets him into the swing of things. Okay, oh, I know. Now the curtain is closed, I'm doing my activity. Next step will be time to go to bed. Melatonin, we said, can be useful. Then make notes, identify triggers. Because if you know that change of shift is really upsetting dad, maybe that's the time you need to visit, to take that edge off that, him feeling so upset that now I have a new person coming in. Limit daytime naps, we said. The other thing is, don't use physical restraints. I know that some nursing homes do use physical restraints, and for them, you know, I think it's important to talk to the caregivers, to the nurses, and see, because you know what they say is allow them to pace up and down, but do it with supervision. You know, walk with them, let them do what they have to do, and then they themselves will say, you know what, I'm tired, I need to go to bed. And then approach them in a calm manner. Don't argue, it's not helpful. Offer reassurance, everything's going to be fine. As soon as you're ready, I'm going to take you back to bed and you're going to be okay. And then another thing to tell them also is that, you know what, it's 8 o'clock, it's bedtime now. So what do you think? Let's finish that round, and it's 8 o'clock, let's try and get you to bed. And then also the other thing is find out if they need something, because maybe they're pacing and they want something, glass of water, something really simple. Okay, so those are some tips. And then REM sleep behavior disorder. This is a very interesting phenomenon, because as we said, during REM sleep, it's an active stage, but your body at that time is not doing anything. You're supposed to be flat and sleeping. And that's, in this disorder, what happens is you have dreams, and you start acting out those dreams. And oftentimes you'll kick, you know, your spouse or whatever, and you can cause serious injury. So that's a problem. And remember that that is present. People with dementia, 1% prevalence. Again, it is associated with medications, like antidepressants can cause that. And alcohol withdrawal triggers sleep deprivation. So for some reason they didn't sleep well the night before, and now what's happening is their sleep is affected, and they're doing this during REM sleep. Some medications can cause that, like SSRIs. These are antidepressants, tricyclic antidepressants. As a side effect, they can affect your REM sleep. How is it diagnosed? So if you do the sleep study, the polysomnogram, during REM sleep, there shouldn't be all this muscle activity. And what's happening is the person is moving around during REM sleep. That's how you diagnose it. Treatment, so what do we do? How do we help them? Clonazepam. Clonazepam is a kind of a benzodiazepine, but you use a very low dose, you know, for them. And then because clonazepam, if you don't regulate it, sometimes it can cause increased falls and worsen cognitive functioning. So you've got to be careful about that, because remember, dementia, fragile. It's a fragile person. Melatonin, then other things like quetiapine. Ensure safety. You want that their bed is in a safe place. They shouldn't be a sharp like this. This is not good, you know, next to their bed. They're going to hurt themselves if they have this. And then padded sharp sides, bed away from the window, because some people, when they're acting out their sleep, have been known to just jump through the window, and they don't know what happened. Because if you think someone is chasing you, the dream, you start running, and lo and behold, you run straight through the window. So you don't want that. Mattress on the floor. If it's that bad, then you want to pad the area so that if they have a fall, they'll land on something that's soft and they can buffer their fall. The thing that's very interesting about this REM behavior disorder is that it's a prodrome biomarker. So for instance, if you don't have signs of dementia or Alzheimer's or anything, but you have this REM behavior disorder and you're having this problem, it could mean that you're at higher risk for developing Parkinson's as you get older. So this is a lot of research in that area. And so it's an early stage, could be an early stage of alpha synucleinopathy. Remember, that's a protein secreted in Parkinson's. And so if the diagnosis is made, at least then you're ready, meaning that as soon as you start having some symptoms, you can get diagnosed. You can start being on treatment for Parkinson's. It's treatable in this day and age, right? And so other things like dementia with Lewy body, that is also a biomarker for that. And so what they did was they showed what was the prevalence of people with RBD, REM behavior disorder, developing dementia. And it was 33.5% in 5 years, 82% in 10 years, and 96% developed dementia in 14 years with this REM behavior disorder. So you really want to take care of them. And Parkinson's seems to be the most common with REM behavior disorder. And the reason why we want to be aggressive and on top of it, because then you can identify individuals at risk even before it has started, which I think is so cool. Obstructive sleep apnea. This is something that's very common, very, very common. And I think what happened maybe 10, 15 years ago, we used to say, oh, you know what, he snores, his father used to snore, his grandfather used to snore, and we didn't really, I think we didn't have a lot of knowledge about it, but now we know that obstructive sleep apnea, oh my gosh, causes all kinds of, it runs havoc in the body. It can affect every single organ, and it can cause all these changes and increase your risk for dementia or Alzheimer's. So currently there's a lot of research and interest in this area. People at risk, we said those who are heavyset, male, more than 60 years. Remember that, you know, and this is kind of sad. I mean, I think it's sad because sometimes, you know, you already have a diagnosis of Alzheimer's and then you realize, you know what, they snored all along. Maybe they had obstructive sleep apnea. Maybe if I treated the obstructive sleep apnea, I could have maybe, you know, sort of slowed down the progress. That's what I think people are looking at as far as research is concerned. Why? Because obstructive sleep apnea, what happens? What does that mean? Do you all know what does obstructive sleep apnea mean? What do you think? So it's snoring, so you're, and then there are periods of time you stop snoring, and then you go gasping. So what happens is when you gasp, your body is telling you, you know what, you need to breathe. You stop breathing. And when that happens, your blood pressure goes up, heart rate goes up. If you're doing that 50 times an hour at night, can you imagine what the long-term effect that is going to be? So that causes a lot of changes, increase of neuroinflammatory markers. You're at risk for hypertension, diabetes, depression. You're at risk for dementia. So you want to treat that because this treatment is so easy. And what's the treatment? CPAP. And what is CPAP? It's just a mask, and it's air that comes under pressure, so it doesn't allow your airway to obstruct during when you sleep and make you snore. That's how CPAP works. I mentioned that. And so as you can see, OSA, I mean, it is every kind of dementia is, those patients are at risk for having obstructive sleep apnea. And then, as I said, it's so interesting that if you treat sleep apnea with CPAP, there's less cognitive decline. I mean, again, how cool is that? That's something you can prevent or prolong, you know. Next. Treatment. Treatment, as we said, is CPAP. Sometimes, you know, we need surgical procedures. For some reason, if we have a small chin, or, you know, if we have a little bit of abnormality here, or maybe problems with our mandible and the maxilla, we may need surgery. There's another thing called hypoglossal nerve stimulation that can be used for treatment of obstructive sleep apnea, but the primary treatment is CPAP. Now, what is the problem with CPAP? What do you think?
Well, from my experience, it dries everything out.
Well, that can be one reason. It dries you out, and that's
My mouth
why,
opens up.
and that's why then you don't want to use it, correct?
I'm still using it.
Are you good for you? Good
Because
for
I
you.
can't breathe without it.
See? And so that's very important, because when you have side effects, that's something to see your doctor and tell them that, this is making me so dry. What are some options? Can I use a different mask? Maybe I need something that just sits over my nose. Or maybe I need a chin strap. Maybe my mouth is opening so much that it gets dry. Because the problem with this is, and she's so good, she uses it in spite of that, many people, they give up. And they're like, you know what, I can't deal with this. And it's obtrusive because it's sitting on your mouth, on your face, and most of us, we don't like at night having something on our face. It's weird, right? And then it's hard turning around from front to back as well. So adherence rates tend to be low. The thing is, insurance tends to be pretty tough, because they say you got to use the machine for more than 4 hours a night 80% of the time. Otherwise, we're going to take away that machine. So, and then I think the most important thing is it will delay cognitive decline. And I think that is just awesome to know that. Next. Tips, a summary. A balanced, heart-healthy diet. The Mediterranean diet is considered one of the best because it has fish, it has your olive oil, healthy oils that you use. It has, what else does the Mediterranean diet have? Is anyone on the Mediterranean diet? That's so funny. But I'm sure, you probably, your diet has 1 or 2 of these things, so that's okay. The other thing that they say is the DASH diet, especially for folks who have hypertension. So you want something that's rich in vegetables, fruits, whole grains, fat-free, low-fat dairy products, fish, poultry, beans, and nuts. And they keep saying, they really are hard on alcohol, but there are studies showing a small glass of red wine is supposed to be good, but try and have it, well before you go to bed. That's what I would say. Staying socially active, like you all have activities for your loved ones that they can engage in. All that it stimulates your brain. Treat these other problems that can affect your sleep. And then you want to make sure that you practice good sleep hygiene. What I mean by that is, keeping a good sleep schedule, avoiding things that you shouldn't right before going to bed, decreasing blue light, and recognizing and treating sleep disorders. COVID. So everything was going not as hunky-dory and fine, and then COVID hit. So COVID has had many challenges because for the older people with maybe dementia, there's a delayed diagnosis, not able to get polysomnograms, CPAP machines, because if you think about it, COVID, if you have that CPAP, and COVID is spread by droplets, so you have to be extremely careful with that. Limited access to health services, increasing isolation, which is not helpful, increased insomnia, which is not helpful. Because if you're in the nursing home and you're on lockdown, your loved ones cannot visit you, and that has been a great problem. This I found, these are some helpful things for caregivers that you could use and make use of. And I think the Alzheimer's Association, they even have a hotline that you could call. And I wanted to dedicate this to my dad, Michael, and he's gone but never forgotten. And he was a very dynamic gentleman. And the thing is, he started having early signs of dementia, but was never actually diagnosed. One thing, he was in a lot of denial. He was like, I don't have it. And so we used to say, Dad, you really need to see, we need to get this taken care of. No, I don't need anything. And I remember he had a lot of sleep problems at night. And those might have been those early things. The only thing I think is a blessing is it's not the Alzheimer's that took him. No. Around that time, he got diagnosed with bladder cancer. It was the bladder cancer that took him. So I don't know whether that was a merciful thing, because over time, if you have someone in denial who's not going to do anything, it's even harder to take care of them. And let's see. That's it. Thank you.
Thank you.
Any questions?
What about the appliance? Is that as good as the CPAP?
Which one? Which appliance?
It's called TAP, is that right? And that would Dr. Larry Hand, makes those here locally. He has them down. And it's appliance for your mouth for obstructive sleep.
And it has the same attached to the machine?
No, it's just I saw you
So
had
I
an
think,
oral
you know,
appliance on it.
Yeah, and so probably the oral appliance, the way they work is probably keep the airway open at night without having anything. Maybe it works, I don't know, because to actually prove if it works or not is to get a sleep study before and after to know how the person is doing after, say, maybe a couple of months of using the appliance. Because, you know, in CPAP, we check. Every 3 months, we get a download. So we know how you're doing on that. We can check your apnea-hypopnea index, and we know if we need to increase the pressure. So the oral appliance, I think that would only be those things, but I would think that folks with mild obstructive sleep apnea, that would probably work very well. And I think those with severe, I think then probably the CPAP machine. But that's a really good, I need to look into it. Yeah, and check that out.
Okay. Any other questions? Anybody experiencing any sleep problems with their loved ones and how to address it?
How do you turn your mind off when you can't sleep because you're thinking and stewing and planning and I've heard the expression turn your mind off. How do you do that?
So a lot of times, because you see, if you don't turn your mind off, then you're going to have insomnia, meaning I can't sleep. So a lot of times I'll say that, you know what, take a book like a diary and start writing those thoughts that you think might keep you up at night. Because many of us, what happens is, the reason why we keep thinking about it is because we're worried that we'll forget to worry about those worries in the daytime. That's what happens, you know? And so we're like so scared, I have to keep thinking about it and I have to think of solutions, all these long drawn solutions. And of course then it stimulates and you're wide awake. So now those are the something simple that you could do. The other thing that you can do is right before going to bed is yoga, relaxation, deep breathing. And then if you've written your worries in a diary and the diary is right there, you can tell yourself, you know what, I've written it all down. I'm not going to forget to worry about it. I'm okay. And now I can focus on going to sleep. If that doesn't work, you could try the warm glass of milk, like your mom said. And if that doesn't work, then you might have maybe a little bit of anxiety. And it doesn't, I think there's no harm talking to your doctor about it. Because sometimes if it's really something that is related to like anxiety or even depression, you know, because remember depression and anxiety sometimes go together. Because you're sad about something and those thoughts keep coming in your head. And then you're tensed up and it's hard to slow down. So sometimes even a small dose of a antidepressant may not be a bad thing in the long run. But those are a couple of things that you could do. Also coloring books, that is sometimes very helpful. Because you know that energy that's going in your head, you're taking out that energy and actually doing something about it. And while you're doing it, have your diary open, because if that thought comes up, you can quickly make a note. Yeah. I hope you found that a little helpful, some of those things. Yeah.
Well, thank you again. We
Oh, not at all, my
appreciate it.
pleasure. And if you do come up with questions later on that we didn't talk about, my email address, you can send me a message. I'm at LSU and Paulette has my email address, and I'll be more than happy to do that. But thank you so much for your attention. You all have a good day now.
Thank you.